Hey everybody, hello, hello. I'm just going to wait a few minutes and see if some people come on. Happy Wednesday. Going to be talking about women's heart health today in honor of Heart and Stroke Month or Heart Month. So that's what I'm going to be talking about today, but I'm just going to wait to see people kind of join in so that we can do this right from the beginning. So I'll just give people just a few more minutes to join. If you're having any questions, don't hesitate to put them in the comments below. I'll try my best to answer them. Hey, Stephanie, thanks for joining. Thanks for the question. Your question is super complicated. So I'm going to do a bit of a touch on it, but I'm going to do a really good video next week about it, okay? Because the question you've asked about insulin resistance is super complicated, not an easy question, but it's great because it's a really good thing for me to review. So just so that you know. So I'm just waiting a few minutes while people join. For those of you that are, hey Karen, thanks for joining. Hi Andrea. Hey Jennifer. I am the first part of these videos. I'm going to be using them for a podcast. So I'm starting up a podcast, and so you're going to notice that I'm introducing the podcast and that kind of stuff, and taking a bit of a pause so that we can cut the audio. So it's going to sound a bit weird, but hang in there with me. So the first part of it, I'm going to do giving you some, tips and tricks and stuff like that. And that audio is going to be used for the podcast. And then if anyone has questions, I will answer those. Those questions are private. Those won't be posted on my podcast unless I get approval from you. So don't worry about that. So let's get started. We have a decent group on now, so that's great. So hey everyone. Oh my goodness, I forgot. Anyways, I need to do my podcast start. So hey everyone, thanks for tuning in to the Unmask and Evolve podcast. This is episode 2. Today we're going into the physical dimension, and we're really going to be talking about heart health in women. So February is Heart and Stroke Month. There's a lot of new evidence saying that women in general are are at higher risk for heart attack and stroke because we're not picking up the signs. So for those of you that are tuning in, thanks for tuning in. This is what we're going to be talking about today. I will, for you Q&A listeners, be answering questions live after the podcast. So if you have questions, please put them in the comments in the Facebook Live feed, and I will get to those. So first thing I want to talk about is heart disease. So when I talk about heart disease is a variety of things. So heart disease is, it can be high blood pressure, it can be high cholesterol, it can be structural problems with the heart. So Karen is saying, I have stenosis of the main aortic heart valve. Yeah, so there's different valves in our heart, and those valves can be thickened or hardened, and that's what we use the word stenosis. We can have an enlarged heart, we can have a saggy heart, we can have a funny heartbeat. All of this stuff is related to heart disease. And how we clot and where we clot is related to the strokes. And where that clot originates from is how we decide what type of stroke it is. So the biggest thing that we want to get the awareness out about is that generally in our medical community, we've always really just focused on men and their risk for heart disease. And women have kind of gone under the radar because we've been focusing so much on breast cancer and cervical cancers and other things. And we've all just believed that, we know that estrogen is cardioprotective. And so we know that most women have protection on board until their 50s. And so we just believe that, they're not really at risk of having a heart attack or stroke. And so we don't really need to be assessing risk factors. And what the data is showing that most of the research out there about heart attacks and strokes are done on men. So 2/3 of the research is done on men. And so what we're finding out is that women are having very different symptoms when they present with a heart attack. And so it's underdiagnosed. We also know that our physiology is a bit different. So we're not just little men, right? Humans are not just humans. It's that there's a genetic and physiological difference between men and women. And most of us know that, right? I mean, of course, we're the superior race, but anyways, or we're superior gender, but we just make the assumption that a human is a human and the body reacts the same way, and it doesn't. And so we're starting to, as a medical community, to become very aware that we need to get the word out there. We need to be teaching women about the signs of heart attack and stroke and about what their risk factors are, and that we shouldn't just be saying that, any woman under the age of 50, because they have estrogen on board, because they haven't gone through menopause, is safe. Because we're setting ourselves up for failure of not being able to diagnose and treat this quickly. So besides women being underrepresented in the research, which will change now that we're aware, physiologically we're different. So when we think about how women present with heart attack symptoms, and I want to talk about what a heart attack is. So a heart attack is when the blood vessels that bring oxygen to the heart tissue, the actual muscle, get blocked. And so there isn't oxygen going to the heart muscle, allowing it to pump, and that causes pain. So pain means lack of oxygen to the muscle, and pain equals time. So as pain occurs, tissue is dying. And so we always that's why when people are presenting with crushing chest pain, especially men, they get into the emergency room very quickly. They're worked up. Most of them are either in an OR having an angiogram or getting clot busting drugs within, 1 to 3 hours of onset, if people present to the emergency department. And so we have done really well at saving people's lives in that. But what we realize is that women present very differently. Their symptoms are much more vague. What we found out is that, and some of this information is new for me, so I've been able to learn quite a lot about this, things that I wasn't necessarily aware of. And this is one of the things that I learned, is that the blood vessels in women are smaller than men, but also that our resting heart rates are a little bit higher than men because of this, to compensate for the smaller blood vessels. What else is really interesting is that, so with typically men, and when we talk about heart attack, we always assume, and what comes to mind is crushing chest pain that radiates down the left arm. It can radiate into the jaw, shortness of breath. It's very much squeezing, diaphoretic, which means sweaty, pale, right? That's what when we say heart attack, that's what most people picture. With women, what's really interesting is they can have those symptoms, but most women don't. And what they're showing is over 60% of women actually present with non-heart pain symptoms. So they usually present with things like indigestion, nausea and vomiting, like an upper abdominal pain, or like an upper back pain. They may show up with fainting or just severe fatigue. And so these are such vague symptoms, right? So lots of women get diagnosed with anxiety. They get diagnosed with indigestion. And so a heart attack may be missed. And so what's really important is what the Heart and Stroke Foundation is saying, is that we really need to be listening to women. And, I've been doing this for a while. And what the Heart and Stroke Foundation has said, which kind of validates my practice, because one of the number one questions I ask people when they come and see me, regardless of why they're there, I always ask them, what do they think the diagnosis is? And the reason why I do that is because it gives me an idea of what their biggest worry is about, where their anxiety is coming from, but it also allows me to get a view of their intuition. Because in all of my years, especially with working in the emergency department for children, what I've come to know is that moms have this gut instinct about their kids, and they bring their kids to the emergency department, and we assess them when we don't see anything, but the mom's like, there's something wrong, there's something wrong. And sure enough, they bring the child back, we assess them, nothing there. But the third time they bring them back and we finally see it. But the moms had this gut instinct for a long time. It's not that the medical system failed her, it's that we couldn't see the symptoms, right? But there's an intuition there. So what the Heart and Stroke Foundation is finding is that when they talk to women after they've been diagnosed with a heart attack and stroke, what they're being told is that the women are saying, you know what, I knew that something more serious was going on. I knew that it wasn't anxiety. I knew that it wasn't indigestion. It wasn't like the indigestion that I had before, or it wasn't, like the worry or the anxiety that I've had before, or the fatigue. I've never experienced this type of fatigue before. So we really need to listen to people when they're saying, this just isn't right. The other thing is that as women, it's important that we advocate, right? And that means speaking our truth. And that is very difficult in the medical community because we hold providers at a very high level and that they are in a position of power. And sometimes we find it very difficult to be able to say, well, you know what, I disagree with you. And, I think this is something else, right? Because, certainly I've seen it where that can certainly backfire on a patient, right? And the provider then goes 180 degrees the other way and doesn't listen, right? So, and I'm not perfect. I have bad days where I haven't listened. I am not bashing on my colleagues because we've all been there where we're just not functioning at our best and we're not listening. Or somebody comes and says, I was looking on Google, and lots of us, our brains are like, oh, for God's sakes. But with time and with experience, I've learned to say, okay, what did you learn? And what was the website? And let's do some education about Google and what can be a really helpful and what can be really not helpful. And then let's look at, okay, what are your fears? What are your symptoms, and work around it versus rolling my eyes and going like, okay, if that's what you're going to diagnose with yourself, because it's not helpful. It breaks down those barriers. So that's a side note. So what we also have learned about heart attacks in women is that, generally heart attacks happen in men in the major arteries that are feeding the heart muscle with oxygen. But with women, it's actually the microvasculature. So when we do angiograms essentially go in and they're like a little camera that look at the big arteries. Usually we're either going in through the wrist or the femur, so down in your groin, or sometimes they go in through the neck, but not very often. They go in through the vasculature, and they go and take a look, right? And they're looking for blockages, but they're looking at those big blood vessels that are providing most of the oxygenated blood to the heart muscle. But with women, it's the microvasculature, and microvasculature means it's the smaller blood vessels. And so those are not picked up on an angiogram. So angiograms are probably not helpful for women. So this is something that is quite new. If anyone's having questions, if I'm talking too fast, let me know. Yeah, so Kim is saying, as someone who has had to avoid estrogen due to the increased risk factors for over half my life, any advice in case I was today's years old in learning the correlation between estrogen and assumed cardiovascular protection, or in my case, a lack thereof, perhaps? And can you create a deficit and detriment on one's health? So no, Kim, because your body is producing estrogen, right? For you, I think what you're talking about is you've had to avoid birth control pills, and I'm going to talk about that because talk about how estrogen is cardioprotective. So I'm going to get to that. So for you, certainly, if you were to take birth control pills, it actually would put you at an increased risk of cardiovascular disease because of the risk of clots and probably high blood pressure. So there is a proportion of women when they're taking contraception that it actually increases their risk of clots and increases their risk of high blood pressure. And so sometimes we have to pull people off. Generally, women under the age of 35, if you're a non-smoker, it won't actually increase your risk of, in most women's risk of cardiovascular disease. In women over 35 who are smokers and you're taking oral birth control, I really hope your provider has told you the risk that you are at risk for heart attack and stroke if you're smoking and taking birth control, oral birth control. Because so an oral birth control, I mean a pill that combines both estrogen and progesterone. It will increase your risk of clots, so stroke, and potentially heart attacks. So I'm going to talk about that. So that's a really great question. So when we think about estrogen, we know that it's cardioprotective, and that's why we start screening men at a much younger age, so usually 40s, or between 40 and 50 for heart disease. And with women, we kind of ignore it because we just assume most women haven't really gone through menopause until 50 or later, right? But the reality is menopause can happen any time after 40, and estrogen is only so protective. If you have risk factors for heart disease, the estrogen on board can't compensate for all of those risk factors. And so it's really important that we're looking at that. So when we think about your risk factors, certainly we know now that gender plays a role. We know that certain ethnicities play a role. So people who are Aboriginal are at a higher risk for cardiovascular disease. And certainly there's other ethnicities, and off the top of my head, I can't think of them. But if you want to know what your risks are, you can go to the heartandstroke.ca website, and I'll post the link at the bottom of this video, and you can actually go in and do your risks. And I was on there today and playing with it a bit. When we're looking at what people's risk factors are, we're looking at age, we're looking at whether they're smoking, we're looking at their cholesterol, we're looking at whether they have high blood pressure, we're looking at whether they're diabetic. But what we're learning about women's heart health is we also should be looking at, okay, what was their pregnancy like? Where are they at from a hormonal point of view, whether they're menopausal, and are they on birth control? And that's not something in my practice that I actually took into account. Looking at, talking to a woman who's at 55, I never really thought about, okay, asking them about their pregnancies and whether they were gestational diabetic or whether they had preeclampsia. Right? So this is really great new information for me to change my practice so that I am being able to explore those risk factors in a more full way. So I would just want to go back to oral birth control pills again. I think I've kind of touched on it with Kim's question, but again, certainly if you are over the age of 35 and you're a smoker, or over the age of 40 and you're on birth control, certainly it can increase your cardiovascular risk of blood clots. And there is a small proportion of women that increases their risks of clots, and it increases their risk of having their blood pressure. And so that's when you're going to get your birth control pills renewed, that's why we're checking your blood pressure. That's why we're, asking you if you have what I call ACEs. Are you having, have you ever chest pain, eye pain, severe headaches, any pain in your legs or limbs? Generally, if you're going to have blood clots because of oral birth control pills, that's going to happen within the first 3 months of you taking those pills. So if you've been on them for many years, then your risk is, you haven't had any contraindications. And certainly when providers are prescribing birth controls, they're looking at your risk. They're wanting to know if you have any problems with your liver and high blood pressure and all these other things. They're usually, we're all screening for these things. So from a pregnancy point of view, what's important is that women who have had gestational diabetes, and gestational diabetes means that because of the pregnancy hormones that are circulating in our body, we end up having insulin resistance. And so our body has to produce more insulin. And this, we need to monitor it during pregnancy for a variety of risks. But what ends up happening is if you've had gestational diabetes in pregnancy, you're actually at higher risk of developing type 2 diabetes later in life. And that's because of insulin resistance. And so, which means, certain risk factors like obesity, high blood pressure, those things. If you're diabetic, you automatically have a 30% chance of heart attack and stroke just by being diabetic. It doesn't matter how fit you are. It doesn't matter what your blood pressure is like. It doesn't matter if you have perfect cholesterol. If you're a type 2 diabetic, you have a 30% chance of heart attack and stroke. And so, we need to be treating, those patients. And so what they're finding in women is that even after women have had heart attacks, where they're not being prescribed antihypertensive drugs or other cholesterol medications to prevent it from coming back again, from occurring again, because people can have heart attacks multiple times, right? This isn't like I have it once, I'm never going to experience it again. I'm immune to it. The other thing is preeclampsia. So preeclampsia is a risk factor for heart attack and stroke because of kind of the anticoagulant stuff, but also because of the hypertension that goes along with it. So some women can just have hypertension in pregnancy. When diagnosed early, a preeclampsia can be treated very well and you can deliver a baby quite healthily. I had preeclampsia in my pregnancy. And so, certainly I'm at higher risk. So, the question is we have to know what our risk factors are, right? We have to know. We have to know what our family history is. Many people that come into my office have no idea what their mother and father's health history is like or what their siblings are like. And this is really important because for risk factors, I'm concerned if every male in your family has died of a massive heart attack or stroke before the age of 50, or female for that matter. And so we need to know that, knowing whether your parents are on cholesterol medications, knowing whether your parents are diabetic, knowing whether your parents have hypertension, because, lots of this has genetic predisposition, right? And so we need to be screening earlier. If a patient comes into my office and they're 35 and they're overweight and they're a smoker, but they tell me that they have a family history of, their father passed of a massive heart attack at the age of 52, I want to do screening. I want to be checking cholesterol, making sure someone's not diabetic. Certainly I have to say, I probably order too much screening blood work, from a choosing wisely point of view of really trying to get away from ordering tests unnecessarily. I think that's one of the things that probably I could improve in my practice. I'm really happy to be in the province of Saskatchewan because the nice thing about Saskatchewan is if you've had any blood tests or imaging anywhere in the province, it's all put in a database where providers from anywhere can access it. And so I can see that. Whereas when I worked in Ontario, if you were a new patient to me, I had nothing. And so I needed to do baseline blood work so that I had an idea of where we sat. Whereas this way, I find in Saskatchewan, I order less because I can actually look at your trends and I can see where you've been at. And whether we need to or not. Generally, the guidelines are if you're over 35 or 40 and you have risk factors, we should be doing blood work to screen for cholesterol and to screen for diabetes. But it's not something we need to do on a yearly basis. It's something we can do every, depending on what those results are, we may need to repeat them every year, but generally if your blood works are normal, we can repeat it every 3 years, but it's really up to your provider. And they will assess the risk, right? Everybody is different. There isn't a cookie cutter approach to everything. So the other risk is when women go into menopause. So menopause means that you've had no period for 365 calendar days. So you could be 49 years old, gone 364 days, and then ended up having a period. You are not in full-blown menopause. You're still premenopausal. But what we know is that once women are menopausal, we know that their cholesterol changes because of the lack of estrogen. We know that their LDL, which is one of the bad cholesterols, and their triglycerides elevate. We know that their HDL, which is their good cholesterol, decreases. And we know that certainly hypertension is more common. Central obesity is more common, so gaining weight in our bellies, and that's where insulin resistant fats is stored, right? And when we start carrying more fat in our bellies, we actually are at increased risk of clots. And so this is something that's really new to me too. I didn't realize this when I was doing some research for today's video. So the other thing is with menopause is that some women go on oral hormone replacement therapy. And that sometimes can increase your risk of heart attack and stroke. Most women were starting to use different forms of hormone replacement where we're using intravaginal or topical preparations which increase or which decrease. So I don't want to give a bad rap to hormone replacement therapy because it does have a place in quality of life in women with experiencing symptoms of menopause. But we do have to also weigh the risks for cardiovascular disease before it's being prescribed. And all providers are very good at assessing those risks. But that is, if you have been on hormone replacement and you've been on it for a very long time. So I've seen people in their 80s who are still taking their hormone replacement. It's really not meant to take for more than 5 years. And so trying to get these people off of it can be a bit of a fight. And so it's really important informing you of the increased risk. Okay. Karen's saying tissues show up in blood work. Actually, there's a blood test that we do, something called a CRP, which is an inflammation test that we do. We use it mostly when people are septic, so when they have a really bad infection that's in their blood. But we also know that we can use it as an indicator for heart disease risk. So sometimes when we have people who may be adopted or their family members are deceased and they don't know what their history is, but they might have a bit more risk, this can be helpful as another tool. There is also another blood test out there that we can also do that can help be able to disseminate risk. The reality is what do we do to manage our risk? And the reality is it's getting adequate sleep. So people underestimate the amount of sleep we get. We're living in a society that is burning the candle at both ends. We are not living healthy lives. We're not honoring this body, which is miraculous. We're treating it awful. We're not taking, it's like we take our car to the garage, we get it detailed, we do all this stuff, we take it to the car wash, but we don't do the same thing with our body, right? So we don't feed it like good fuel. We feed it crap. We don't exercise. We don't sleep. Some of us are smoking cigarettes, which increases our risk. Some people are drinking too much alcohol, doing drugs, those types of things, and those will all increase your risk. And so when we think about women, well, if we can't do an angiogram to figure out if they're at risk, what do we tell people? We tell women, just like we tell men, that we need to manage, eat healthy, make sure we're getting 150 minutes of vigorous exercise a week. And that can be in 10-minute blocks. It doesn't have to be an hour of unrealistic exercise 3 times a week. And it can be as simple as just starting to walk. It's about eating whole foods. I can't stress that enough. Getting rid of the junk and the high fat and the processed foods, eliminating or trying to decrease the amount of sugar and flour in your diet is super important. Managing our stress is really important. We are in a phase, or our lifestyles right now we're overstressed, and we are, affecting our overall health because of our stress. Stress hormones will increase. So our stress hormone is cortisol. It increases the stored fat in our bellies. It increases our fatigue. It increases our sugar and flour cravings. I mean, it's a hamster wheel, right? It's hard to get off of. Um, yeah, I think that's really kind of all I want to say about that. Um, Yeah, so we need to be taking better care of ourselves, not just for our heart health, but for our overall health. If we prioritize our diet and our exercise and weight management, and I say that as somebody who struggles um, with her weight, that it doesn't mean weight management doesn't necessarily mean losing 50 pounds or 70 pounds or 100 pounds or whatever that you're overweight. It means decreasing your risk. So sometimes just losing 20 pounds or 10% of your body weight has an incredible impact on your cholesterol, on your blood pressure, on your blood sugar. So I've seen this over and over again, but our society that is very diet centric, that is very focused on BMI, that is very much body shaming, perpetuates this feeling of shame and guilt. And so it makes it really difficult to institute those habits. Do I think you need to institute all these habits in one day? Absolutely not. We can't. We'll overwhelm ourselves. We will white knuckle it, and we won't. So it's about starting with one habit. It's about improving your life by 1%. So if that is just making sure you go to bed earlier every night, that improves your health. I am not naive enough to say to a smoker, smoking is bad for your health. Everybody knows smoking is bad to your health, but it's an addiction. It's easier said than done. And so my job is to be there when they're ready. It's to assess people's readiness for change. It's same with weight loss. It's about assessing readiness to change, and not everybody is there yet, but it's about looking at your life and saying, what can I improve by 1%? And maybe that means, that you go to bed earlier 3 days a week. That's 1%, right? That's not huge, but doing that 1% consistently, that's when we see results. The 1% means you're doing it and it seems like it's not making a difference, but in 3 months, it's made a huge impact. In 6 months, it's made a huge impact. It's not about drastically decreasing your calories, going to a vegan diet, running 3 times a week, you know, it's just unattainable if that's our focus. And so it's really about looking at what that 1% is. And for some people, that 1% is, you know what? I'm not going to drink pop. That's it. Sometimes that 1% is, you know what? I'm going to try and decrease the amount of cigarettes that I smoke by 2 a day. It's about meeting people where they're at. So this is the end of episode 2 podcast. Thank you, everybody that's tuned in. I really enjoyed talking to you. Please comment, reach out to me. You can find me on Facebook at Unmask and Evolve, which is the private page. My business page is Unmask and Evolve Holistic Health and Wellness. You can find me at www.unmaskandevolve.ca, and you can actually find me on Instagram. I got Instagram this week and I'm figuring it out. I'm a bit of a dinosaur, but I'm figuring it out, and that's Unmask and Evolve as well. So follow me for health and wellness tips. I'm a nurse practitioner with 17 years of experience. I've been a nurse practitioner for 8 of those years. And I really believe that in order for us to achieve health and wellness, for us to step into our power and live authentically, we need to balance in the 4 directions of the medicine wheel based on Aboriginal tradition. So balancing in the emotional, mental, physical, and spiritual selves. And so that's what this podcast is about. So today we talked about the physical dimension. Stay tuned for episode 3, which will be a more spiritual talk. So yeah, we'll see you later. Take care. Bye. Thanks for tuning in. Okay, everyone, stay on. I'm going to answer your questions. That's for the podcast. So I know that seems really, really, really weird. But I have to pause a bit and do that ending because that's how I cut the audio for the podcast, which I'm super, super excited about. So I had an amazing question. Okay, so Karen was asking, swelling can be a sign of heart issues, right? Yeah. So, yeah, swelling can be. So, in heart failure, so I think what we think that the heart is a standalone organ, but the reality is if we have kidney problems, um, and high blood pressure causes kidney problems, and kidney problems causes heart problems, and it's kind of like the perfect storm, right? Breathing problems. So people with chronic obstructive pulmonary disease, they can get into heart failure because it's putting pressure on the heart because of the lack of oxygenation or around. So lots of different systems can impact our heart and our heart's well-being. And so when we see swelling, specifically bilaterally in people's lower legs, especially when I call it pitting, when I can push into it and keeps a dent and it takes a while to come out, I always have to be thinking about heart failure. So there's two types of heart failure. There's right-sided heart failure and left-sided heart failure. And all that means is where is the excess fluid pooling? Is it pooling in the extremities or is it pooling in the lungs, right? And so assessing people's lungs is important because generally if someone's having some fluid retention in their legs, it could definitely be related. Definitely in the elderly, it can be called dependent edema. Okay, so it can be related to poor vascular flow just because of aging, because as we age, we all get atherosclerosis. Atherosclerosis is hardening of the arteries, and the blood flow just, our arteries are a pump system. The veins are not. And the veins that bring the blood back to the heart, they pump based on mechanical pressure from the muscles in the calves and the legs and in our body. And so when people are sedentary and they're not moving, that doesn't allow their body to pump that blood back to the heart. And so, one of the questions I ask people to be able to decipher whether this is a lung issue or whether this is just pooling because of inactivity, maybe some compression in the veins or the vasculature in the pelvis because of being obesity. I ask them a couple things. It's that, how are you sleeping at night? Can you lay flat or do you need a whole bunch of pillows because you're short of breath? Are you short of breath when you're walking? Do you have a cough? Are you coughing anything up? I'm also looking at things like, what is their blood pressure like? What is their kidney function like? To decide that. Lots of times in the elderly, it can be what we call dependent edema. And so the way we treat it is compression stockings can be really helpful because it's providing that pressure that the calf isn't doing because people are not mobilizing. Sometimes we have to put people on water pills. So everybody calls them water pills. So they're diuretics, things like Lasix, spironolactone. Sometimes that can be helpful. Those drugs are definitely helpful when someone's in heart failure, and managing their cardiovascular risk. So managing their blood pressure is really important. So when heart failure occurs because of unmanaged high blood pressure, when people have high blood pressure, the heart is working against pressure, right? So you think about when you go to the gym and you lift a weight, you get a big muscle, right? And so when the heart is pushing against external pressure, the heart gets bigger, but unfortunately the heart doesn't get stronger. It gets lazier. And the heart isn't a nice, like your Valentine's Day heart, right? It's 4 chambers, so it's kind of like a blob. And the left ventricle, so the chamber that's in the left bottom of the heart, that's the part of the heart that is pumping out to the rest of the body. And if it's doing that under pressure, it gets saggy and lazy. And so what ends up happening is blood backflows. And it can backflow into the heart, into the lungs and into the lower extremities. And so managing our risks of our cardiovascular risks are incredibly important. And then getting that excess fluid off the body is how we treat that. So so hopefully that helps. There is a blood test that we do sometimes to see if that swelling, because sometimes it's hard to tell, right? You have somebody who has COPD, so chronic obstructive pulmonary disease, and they're short of breath. they have heart disease, they're diabetic, they have swelling in their legs. Sometimes it's hard to tease out what's causing it. And so there is a blood test called BNP that we do, and that can give me an idea of how well managed it is, or how well, if it's not. So it can help me figure out the diagnosis. So the other thing in swelling in the legs is if it's only in one leg, then I'm not worried about heart related. Anything that's heart related always happens on both sides of the body. If you put your legs up at night and the swelling gets better, that tells me it's more just dependent edema. That can be because of low protein in the blood. So protein in the blood, something called albumin, is what holds fluid into the vasculature. So I see this a lot in patients who are malnourished. They can get swelling. In patients who have eating disorders, specifically bulimia, where they're using laxatives, when they stop laxatives cold turkey, they will get swelling in their extremities because of the shift in fluid. So there's lots of reasons for swelling. So it's really good to go and have that checked out by your primary care provider. So I also had a really great question from Stephanie about insulin resistance. Insulin resistance is a pretty hot topic. It's a hot topic for weight loss. It's a hot topic for people who are at risk for, or who are type 2 diabetic, because type 2 diabetes is all about insulin resistance. People who are at risk for, so metabolic syndrome is all about insulin resistance. Polycystic ovarian syndrome is all about insulin resistance. Anybody who has truncal obesity, insulin resistance. And so it's a really hot topic. It's a really complicated one. It's complicated, and I really won't be able to do it justice without doing some more reading and really collecting my thoughts about it, because I really think it's an excellent topic. I've learned a lot about it because of my weight loss journey, and I didn't understand it. So insulin is a hormone that's produced by the pancreas. And so when people are type 1 diabetic, they don't produce insulin, right? For whatever reason, something has happened. We really don't understand the reason. It could be environmental. We're not sure. It's the perfect storm, but the pancreas just stops producing insulin. Whereas in type 2 diabetes, what ends up happening is that you have insulin resistance. So you have fat cells so when you eat something that has sugar in it, so it doesn't necessarily have to, so flour, pasta, that's equal to sugar, right? It's a carbohydrate. Carbohydrates are broken down into sugar. So when you eat something like that, so not when you eat meat, not when you eat cheese, because that's not a carbohydrate. When you eat that, your body breaks it down into sugar molecules. And in order for that sugar to be used by the body, it has to go into the cells. And insulin is like the lock that opens the door to the cells for the bloodstream. And it allows the sugar to go into the cells to be used for energy. But when you have insulin resistance, what happens is that your body is producing insulin, but it's like the locksmith came and changed all the locks on the doors. It's like the insulin doesn't work. It doesn't open up the cells to accept that. So the sugar is transformed into fat. It's saved into fat. The problem with that is that our brain only energy source is sugar. And so what ends up happening is the brain says, okay, well, despite us eating, it starts breaking down muscle in order to get sugar, which is bad because it can't tell the difference between some extra extra fat on our bum or our belly, and it'll break down your heart. So that's the biggest concern when people are starving, is because their body needs to feed itself in order to survive, specifically the brain. But what's interesting about insulin resistance, so then what ends up happening is like it's this big wheel, right? So then you gain weight, you get more insulin resistant cells. Then your body produces more insulin. And so when your body gets tired of kind of producing that insulin, so the insulin production slows down, plus the insulin is not it's like it's the wrong locks for the keys, that's when type 2 diabetes. And so that's when we see the increase in sugar in the blood. And then your body's trying to get rid of it through peeing it out, right? And so that's the physiology about that. But what's interesting about it is that when we have insulin resistance, we also have a problem with something called leptin. Leptin's the hormone in our body that tells us we're full and tells us we need to move. And the problem is when we have insulin resistance, we also have leptin resistance. So what happens to our brain is that it tells us that it doesn't tell us that we're full, and it doesn't tell us to move. And so we end up getting sluggish. We get we don't feel full, so we don't have hunger cues, and we have cravings, right? So most of us, if we're eating sugar and flour, we get cravings, and so then we get more insulin resistance, we get more leptin resistance, we get more weight gain. It's crazy. So, how do we fix this, right? Which is the biggest question. And so that's where, like, for patients who are type 2 diabetic and have polycystic ovarian syndrome, this is where the keto diet has been talked about a lot, and there is research about it. I'm skeptical a little bit, because I think the keto diet in itself, the way it is, because it says, you can't eat fruit and it's limited, it's not realistic from a lifestyle perspective. And anything that's diet, our diet culture sets us up for failure. And so I'm really careful about that. I think it's important that we have lifestyle changes. I think it's important that we have to change our relationship with food. We can't have guilt and we can't have shame. But it's interesting when we think about leptin resistance and insulin resistance, because it becomes a brain issue, right? Our brain starts to sabotage us when we try to lose weight. So many of us, we have never actually experienced hunger. And for me, on my journey, so many of you guys know that I've been on a journey of weight loss, and I've lost 80 pounds. And what I've learned is that I never really felt hunger before, because I just always ate. I mean, our society very much is like 3 meals a day, 3 snacks. I mean, we eat, but also when you have insulin resistance and you don't have leptin, and we are eating high sugary processed foods, we're getting major cravings. And so for me, the only time I have hunger is when I've gotten into sugar and flour, and then I end up feeling hunger, right? Because my body is telling me it wants more sugar and flour. It's not physiologically hungry. But you could easily think about that because it's uncomfortable, and it's hard to ignore. So I mean, I could go on about, but that's my personal journey with that. Yeah, Steph, that's why it explains why you're tired. Exactly. The other thing is that so when we think about insulin resistance and the solution for that, it's really about getting rid of sugar and flour out of your diet. And sugar, I mean, like white sugar, cane sugar, coconut sugar, maple syrup, any sugar substitute. I'm not talking about fruit necessarily. Certainly we need to watch how much fruit we're eating. And the problem with our society is we eat too much. So having bound meals where we have certain quantities, for me, what works for me is eating 3 meals a day and no snacks, and weighing measuring my food, or using a 1 plate rule, so that I'm able, because my brain is broken, I'm a pickle, right? My brain is messed when it comes to food cues. So then it allows me to be able to know that I have enough, because I will always eat more. I will always convince myself that I need to eat more. And when we do that, and we know that hunger is not starvation, and we're not going to die, right? It's not, and we don't get panicked, because I don't know any of you, but for me, I used to get panicked, like, oh my God, it's lunchtime and I'm in a meeting. When am I going to eat? Oh my God, I better eat before the meeting so I don't get hungry. Like, it's so crazy. We're not going to starve to death. We live in a world of abundance. But the other thing is that certainly there's been some research saying that with insulin resistance, with patients with type 2 diabetes and polycystic ovarian syndrome is that exercise is very helpful as well. So changing our diet as well as exercise. The thing is exercise has never really been proven to decrease our weight. And what we have to realize is when we're decreasing our caloric intake, we are putting ourselves in a starvation. And so starvation is exhausting. Weight loss is exhausting. And I say this from personal experience. And from what I've learned and read is that we need to give ourselves space and time. And when I was losing that weight, I was napping every single day. I was getting, I made sure that I got 8 hours of sleep every single night because that was part of my program. But I was sleeping much more than that because I was absolutely exhausted, because you're putting your body in a starvation state. And so it's unrealistic unless exercise is part of your everyday routine, that you don't even think about it because it's part of your mental health and that's just what you do. But if you're having to white knuckle it, if you're having to use willpower to do that, there's no way you're going to be able to maintain that lifestyle change. And that's what ends up happening. We're usually really good for about 21 days, but then we don't see any results on the scale. We're sore as hell. We're exhausted and we're freaking hungry. And so then after 21 days or 3 weeks, we're like, screw this. And then we go back to our old ways, right? Or we try to put in 5 weeks, and that's when I see people fall off the wagon as well. And so that's my 2 cents on that. And that's just from my personal experience. For me, keto diet can be very dangerous because it puts ketones in the blood, which can put you at risk for seizures. Certainly, I think that if that's something that you're doing, it's something that you should really be talking about your provider with. Certainly, the only time I've seen that keto diets are really important is with children with seizures. So, for me, it's like if you pick it off a tree and out of the ground and it's natural, my philosophy is more that a whole eating diet. Certainly, I don't eat a grain or a starch with every meal. I have my grain, which I have oatmeal every single morning. And now that I'm on maintenance, so I'm trying to maintain my weight, I usually have a small portion of starch, which is either, rice or potato at dinner, right? So, when you're in that weight loss phase, you may, from a dirty keto kind of thing, want to eliminate that starch. But the other thing is you need to be balancing that with good fats. And I say this because I didn't balance at first. I wasn't eating enough fat and I lost a lot of hair because my body was in starvation, right? And I want to tell you that I never felt hungry that whole time. So it's really quite interesting. So I could talk forever about that. My personal experience, some of the science behind that, but I hope, Stephanie, that's answered it. If you want me to do a longer video about it, I certainly can, but I think I might have covered it okay just off the top of my head. I wasn't sure that I'd be able to do that. Does anybody else have any health questions? Yeah, Shannon saying really interesting fact about the preeclampsia because all 4 of her pregnancies. Yeah. And you had 4 premature babies. I know. And scary deliveries. Yeah, really interesting. And that's a new fact for me too. Like, when I think about what's my heart health, generally I come from a pretty healthy family of heart health, but I didn't, and I also had insulin, glucose impaired fasting when I was in my pregnancy, as well as preeclampsia. So it's really interesting how that will affect my heart attack and stroke, whereas I wouldn't necessarily have thought that I had a heart risk. So really interesting. Okay, Steph, I'm glad you thought that was in depth enough. I did the best that I can, but I've been learning a lot about that, and it's a bit mind-boggling, the science behind it. But yeah, if anything else comes up, don't hesitate to ask. I hope that was informative. I hope that that everybody had their questions answered. Don't hesitate to private message me if you have a question. And I'll always ask if you want that answered publicly, or I'll keep your name anonymously. So don't be shy. Reach out to me. I love answering people's questions, and I love teaching. And I love doing these videos. So it was really nice to spend my Wednesday evening with you. I hope everyone is doing well, and I will talk to you soon. So for those of you that are following me on Facebook and Twitter and all those kind of stuff, it's Sexual Health and Relationships Week, which is why I'm posting a lot of stuff about sex. So please bear with me. Hopefully I'm not turning a lot of you guys off. But it's a really, really important topic that also needs a lot of attention. So I'm going to be doing a lot of more posts this week. It is also, what else is this week? Oh, Heart and Stroke Month, which is really important. So what you're going to find is that what I'm posting is based on the weeks and the days of the month, because I think that's a great way to be able to stay current and on top of upcoming data and health information. And it's super interesting for me. So let me know what you want to hear about. Private message me, put it in the comments. And thanks for watching. Take care. Bye, guys.